Hello, welcome back. In the lecture on patients with diabetes mellitus and stage 4 and 5 chronic kidney disease, you heard about the possibility of beta cell replacement therapy in addition to kidney transplantation. The two options of beta cell replacement therapy are pancreas transplantation and islet transplantation. Since patients need to make informed decisions about these procedures, aren't you curious how they are performed? And don't you wonder which of these two options is best for which patient? We will find out in this lecture. First, we should answer the question which patients are eligible for beta cell replacement therapy. In general, patients with stage 4 and 5 chronic kidney disease and diabetes mellitus due to severe beta cell failure are good candidates. Usually, it concerns patients with type 1 diabetes. Kidney disease in this patient group is often caused by long-term hyperglycemia, and unstable glycemia with frequent hypoglycemic events in patients with type 1 diabetes can also be an important factor to consider. Sometimes, non-obese, insulin-treated patients with diabetes mellitus and considerable remaining beta cell function are also considered for beta cell replacement therapy. But what beta cell replacement therapy option should be chosen for which patient? Here you can see a decision tree that can help you making good decisions together with your patients. If your patient has diabetes mellitus due to severe beta cell failure and stage 4 or 5 chronic kidney disease, the anticipated time on dialysis is an important decision point. Dialysis for longer time periods is associated with increased morbidity, mortality, and reduction in quality of life. Preferably, patients should be transplanted before dialysis is initiated, thus in a preemptive setting. If pancreas transplantation is surgically feasible, a combined pancreas kidney transplantation should be performed. If patients are already on dialysis, but the time on the transplantation waiting list for a combined pancreas kidney transplantation is short, a combined pancreas kidney transplantation should still be considered. However, if there is a long transplantation waiting time and a living donor is available, a living donor kidney transplantation is a good option, which can be followed by pancreas after kidney transplantation at a later time point. But if a pancreas transplantation is not an option after a living donor or deceased donor kidney transplantation, islet after kidney transplantation is a good strategy. Now, my colleague Dr. Huurman will discuss the pancreas procurement and transplantation procedure.
Hello everyone. In pancreas kidney transplantation, a donor pancreas and kidney are retrieved from a deceased donor. The pancreas is procured, including part of the duodenum and the spleen. Because of the complicated vasculature, meticulous preparation of the pancreas before transplantation is very important. And unfortunately, in some cases, damage to the organ capsule or parenchyma occurs during retrieval. If you want to familiarize yourself in detail with pancreas procurement, surgeons may visit www.modsurgery.org. In the following pictures, you can see the preparation of the pancreas. The spleen is removed, the duodenum is reduced and oversewn, the bowel mesentery and all small vessels are closed, and the two main arteries supplying blood to the pancreas, the splenic and superior mesenteric artery, are merged using a Y-shaped graft. In most cases, this is a piece of iliac artery from the organ donor, and after this, the organ is ready for transplantation. In the following video, a short impression of simultaneous pancreas kidney transplantation will be given.
In the following video, the essential steps of combined pancreas kidney transplantation are shown. The kidney and pancreas are meticulously prepared before the transplantation. For the pancreas, the spleen is removed from the pancreas and the splenic and other remaining vessels are ligated. The end of the duodenum and the mesentery are shortened and oversewn. The superior mesenteric and splenic artery are joined into one artery using a Y-shaped graft of donor artery. A median laparotomy is performed and the distal aorta, vena cava and iliac vessels are exposed. The kidney is placed first into the left iliac fossa. The artery, the vein and the ureter are anastomosed as shown before. Next, the pancreas is placed into the right iliac fossa. The portal vein is connected to the distal caval vein, the artery to the iliac artery, and the duodenum of the graft is connected to the small bowel of the recipient. After this, the abdomen is drained and closed.
So, with good patient selection, pancreas transplantation is a successful procedure. Over 75% of the transplanted pancreases is still functioning well 5 years after a combined pancreas kidney transplantation, with patients not needing to use insulin. This graph depicts pancreas transplant graft survival at the Leiden University Medical Center, with a dotted line before 1999 and a straight line since 1999. Nevertheless, this procedure has a considerable chance of complications, including blood loss, thrombosis, bowel leakage, and transplant rejection. These problems will be discussed in another lecture.
The other option for beta cell replacement therapy is islet transplantation. Most of the complications related to pancreas transplantation are due to the exocrine portion of the pancreas that produces digestive enzymes. This exocrine portion constitutes 99% of the pancreas. The approximately 1 million islets of Langerhans make up the endocrine portion, which is only 1% of the pancreas. Since in patients with severe beta cell failure the islets are affected, a procedure to isolate the islets from a pancreas, followed by an infusion into the liver, was developed. The following video will show you the different steps in the islet isolation and transplantation procedure. Think about what information you would communicate to your patient. What are potential complications, and how can the procedure influence islet function? At the Human Eyelid Isolation Laboratory, a donor pancreas has been received for pancreatic islet isolation. Under sterile conditions, the pancreas is prepared. Blood vessels and excess fat tissue are removed. The main pancreatic duct is identified. The duodenum and spleen are also removed. Approximately 1 million pancreatic islets are dispersed throughout the pancreas. The islets, depicted in red, are surrounded by exocrine tissue, depicted in green. Insulin-producing beta cells are the main hormonal cell type in the pancreatic islets. To continue islet isolation, a small catheter is inserted in the main pancreatic duct. Subsequently, an enzyme solution containing collagenase is infused through the catheter. Collagenase that leaks out of the pancreas is reinfused. Meanwhile, a digestion system is prepared. This system contains a digestion chamber with iron marbles. The pancreas is cut into pieces, which are put in the chamber, and a lid is attached. A warm solution is pumped through the digestion system, including the chamber. The chamber is shaken so that the pancreatic islets can be freed from the exocrine tissue. Samples are taken from the recirculation solution to monitor the digestion process under a microscope. If the islets are free from the exocrine tissue, islets are collected in conical tubes. The conical tubes containing the islets and small pieces of exocrine tissue are placed in a cold centrifuge. The digestion solution is removed and a cold washing solution is added in order to stop the digestion process and protect the islets from the collagenase enzyme as much as possible. The washing procedure will be repeated and the digested tissue is put in another solution for eyelid purification. In order to purify the islets, a continuous density gradient is made using a high density and low density solution in the spinning compartment of a cell separator machine. This density gradient is important to separate the lighter islets from the denser exocrine tissue. By reversing the flow in the cell separator, fractions can be collected that are either enriched for the islets or contain mainly small pieces of exocrine tissue. The fractions containing islets with acceptable eyelid purity are put in a transfusion bag. In this way, there is a considerable tissue volume reduction while using the majority of the islets for transplantation. The transfusion bag containing the islets is placed in an incubator. Safety testing for bacterial contamination and function testing for glucose-stimulated insulin secretion are performed for quality purposes. If the islets are released for transplantation, the transfusion bag with the islets is transferred to the radiology department where the islet transplantation takes place. Under local anesthesia, a radiologist performs a percutaneous transhepatic catheterization of the portal vein under ultrasound guidance. A catheter is inserted into the portal vein. The transfusion bag is connected to the catheter. The pancreatic islets are infused in approximately 20 minutes. The islets embolize the small branches of the portal vein without major adverse consequences. In fact, the liver has now adopted pancreatic islets, and the islets start producing insulin in the liver of the recipient. Islet transplantation is successful in the majority of patients. This graph shows results of islet after kidney transplantation at the Leiden University Medical Center. The left panel shows that in approximately 60% of patients, insulin independence was achieved. Despite the fact that not all patients are insulin independent and that this rate decreases over time, the right panel indicates that islet graft function is achieved in the majority of transplanted patients and is maintained for long time periods. So now you have observed both pancreas and islet transplantation procedures. Are you now able to provide relevant information about these procedures to your patients? With regard to functional outcome, simultaneous pancreas kidney transplantation has the highest chance that patients will become insulin independent, followed by pancreas after kidney transplantation and islet after kidney transplantation. However, also when insulin independence is not achieved, despite functioning islets, a situation termed partial graft function, there are important clinical benefits on progression of complications, protection of kidney graft function, glycemic stability, hypoglycemic events, and quality of life. Functional outcome of pancreas and islet transplantation and its clinical benefits should be weighed against the risks of the procedure. The risk of complications is substantially higher in pancreas transplantation, which is a major surgical intervention, compared to islet transplantation, which is a minimally invasive islet infusion. These differences in functional outcome and differences in risks between procedures should be discussed with your patients in order to manage expectations. In this lecture, we spoke about transplantation procedures in patients with stage 4 or 5 chronic kidney disease and diabetes mellitus due to severe beta cell failure. What have you learned? First, if possible, your patient should have a combined pancreas kidney transplantation before the initiation of dialysis. The anticipated time on dialysis is an important factor in deciding the best transplantation strategy for your patient. Then, it was shown that meticulous surgical retrieval, preparation, and transplantation of the pancreas are very important for functional outcome and avoidance of complications. Islet transplantation, which is an infusion of isolated islets into the portal vein of the liver, carries a minimal procedure-related risk and is a good transplantation option after kidney transplantation has been performed. And lastly, pancreas transplantation has superior functional outcome, especially in the setting of combined pancreas kidney transplantation compared to islet after kidney transplantation. However, it should be remembered that also partial graft function has beneficial effects on glycemic stability, kidney transplant function, and progression of complications. In the next lecture of this module, we will present 2 patient cases and we will discuss the different options. Would you make the same decisions that we have made? And what are your considerations? Please join us in this next lecture.